All right, everyone. So we are going to begin the webinar now. So good afternoon. My name is Anna Duncan. My pronouns are she, her, hers, and I'm a program coordinator at CoLab for Community and Behavioral Health Policy. On behalf of our team, I want to thank you so much for being here and for joining our webinar. This is the second installment of a three-part webinar series we are hosting on pediatric integrated care. And to begin, we'll start with a land acknowledgement. CoLab for Community and Behavioral Health Policy and the University of Washington acknowledge that there are 29 federally recognized and 7 non-federally recognized tribes within Washington state. Within Seattle and where we are located, we acknowledge the Coast Salish peoples of this land in Seattle, the land which touches the shared waters of all tribes and bands within the Duwamish, Puyallup, Squamish, Tulalip, and Muckleshoot nations. As we move forward in advocating for and moving toward health and racial equity, let us remember that we are living in a history-driven present. Let us learn more about the histories, cultures, and traditions of Indigenous people and how we might build relationships with sovereign tribal nations and create more inclusive spaces that foster innovation, collaboration, and empowerment. We encourage you to consult nativeland.ca to learn more. Next slide, please. So before we begin the official presentation, I'd like to do some Zoom housekeeping. If you encounter any tech issues during the webinar, please send us a message through the chat box, which we'll be monitoring throughout the presentation, and that is highlighted in red below. We'll also have a Q&A session after the presentations. So if you have a content-related question, we ask that you please send it through the Q&A function, which again should be down below highlighted in purple. Please note that all content-related questions will be answered after the main presentation, so we'll try to get to all of those at the end rather than intermittently in between. Also, if you have a question for a specific panelist, please mention their name as well. During the end, you're also welcome to use the raise hand function, and we can hopefully be able to unmute you, although to be fair, Zoom is being a little funky with our ability to mute and unmute, so we may have to just mainly function through the Q&A box. Also, as a reminder, we will be recording this webinar and uploading it to our website. Next slide, please. As a reminder, this webinar series is approved as the CME credit provider through the AAFP, which is the American Academy of Family Physicians. You don't have to attend all 3 webinars to receive credit. They can be done in an a la carte fashion. However, of course, we'd love to see you at all 3 installments. For AAFP members, you can self-report this credit directly through their website or by contacting them. And for those who are not AAFP members, please check with whatever entity you usually submit CME credits to, and they can let you know whether or not this counts. We're also happy to provide a certificate of completion or to just answer any additional questions you may have. So feel free to contact us at uwcolab@gmail.com. All right, next slide, please. At the end of the webinar, we'll send an evaluation survey link through the Zoom chat. So if you can, please fill it out with any feedback you may have so that we can improve our future webinars. You'll also get an email with that link, so if you don't have time to fill it out today, that's not a problem. We would also really encourage you to share additional topics that you might like to see future webinars focus on. Next slide, please. And before I turn it over to our presenters, I think we're going to take a look at our live poll results to see who's in the room with us. So it looks like, as predicted, we have a pretty high turnout with healthcare members, along with some around academia, advocates, and direct service. So that's wonderful, and thank you again for sharing that with us. It's helpful to know kind of who's here and who's in the room. All right, and again, just before I hand it over, I just want to thank you all for being here. We at the CoLab for Community and Behavioral Health Policy are really excited to host this webinar series and are excited to have you here today. As previously mentioned, today's webinar is the first of a 3-part series focused on pediatric integrated care and what we can learn from this exciting healthcare model. The final webinar installment will take place on Friday, December 3rd from 1 to 2:30, and we'd love to have you back for that. However, as mentioned before, all of our webinars will be uploaded on our website for you to view at your convenience. And for those of you who are joining us for the first time, the CoLab for Community and Behavioral Health Policy was founded in 2020 within the Department of Psychiatry and Behavioral Health Sciences at the University of Washington School of Medicine. The CoLab engages community expertise and research evidence to spark creative and sustainable change in behavioral health policy and systems, particularly those involving youth and families. We believe communities and systems have deep knowledge and expertise that must be leveraged to promote effective, sustainable, and impactful community programs and strategies. For today's webinar, we're really excited to have two wonderful speakers, and I'll let you introduce themselves, tell you more about them. But briefly, it will be Dr. Cheryl Morelli and Laura Morano. And again, I will hand it over to them. They both are part of the Seattle Children's Care Network, and they will be presenting on pediatric care best practices to implement evidence-informed mental health care. Without further ado, I will hand it over to you, Cheryl.
Thanks, Anna. Hi, everyone. So yeah, as Anna mentioned, I'm Cheryl Morelli. I'm a general pediatrician, and I practice at the University of Washington Neighborhood Clinic in Kent, Des Moines, where we have had some form of an integrated behavioral mental health program for the past about 10 years. It continues to evolve, but I have nice experience there that I'm drawing from in part of in this presentation today. And I have a partner in crime, Laura, who is joining me. So we work together for the Seattle Children's Care Network, and we have worked together there since 2017. I believe, Laura, I had that right. So I'm going to start us off. If we can go to the next slide.
Uh-oh, it looks like our slides shifted here. I'm going to share here just to make it.
Okay, thanks. Yeah, I'm going to start. I'll just go through the agenda real quickly, and I'm going to do the beginning part of the presentation. Laura is going to do the middle, and I'll wrap us up again at the end. And then hopefully we'll leave enough time for some nice questions and dialogue at the end.
No problem. I'm just going to, while you start, I will just get these slides back up. All right, can you all see that okay?
Great.
Perfect.
Yeah, so if we can go to the next slide. Just a quick, Laura and I have nothing to disclose, so no potential conflicts of interest and no actual conflicts at all. Next slide, please. So as I mentioned, I'm going to just talk a little bit about planning your project, which is not the most exciting, honestly. I think that Laura has the more fun part of the presentation, talking about the actual implementing and motivation for change. And then I'll wrap up with a little bit at the end with the sustain. If you can go to the next slide, please. So I'm not going to read the objectives to you. You guys can see them here, but really big picture, what we hope is at the end of this, for those of you considering this model, you'll be a little closer to having the tools you need to get moving. For those who are already in this model, hopefully you will learn a little bit from a PDSA standpoint on how you can improve upon what you're already doing and work towards sustain. So if we go to the next slide, please. So at the beginning, especially for those of you who are not here yet, the big part of what you have to do first is sell this idea to all your stakeholders. So if we can go to the next slide. It really is important to stay grounded in the why. Why is this so important? And probably this is not news to anyone who is on this webinar, but behavioral mental health conditions are super common in pediatrics. So about 1 in 7 in the younger age group have some mental, behavioral, or developmental disorder. And about 1 in 5 when we get to the older kids have a diagnosable psychiatric condition. And that doesn't count all the kids who just have symptoms of behavioral mental health conditions, but don't rise to the level of diagnosing. So even though these are super common, and this, again, not news to any of you probably, most of these kids do not receive any care for their behavioral mental health conditions. And there's lots of reasons for the why behind that, but most do not. And when they do seek care, there are really long delays. And those in the past 2 years, the delays are just getting longer. So it really can range for some days, months, years, and even decades. And probably, again, not news to anybody on this call, but suicide now is the second leading cause of death in 10 to 24-year-olds in our state. And in the Northwest and in general, we have higher rates of suicide and lots that go into that. So next slide, please. So once you kind of have framed the, why is this so important? Why should we be focused on this? You really do have to acknowledge, well, then why aren't we doing more about it already? Why don't these models already exist for us in primary care? And there's lots of challenges and barriers to doing mental health in primary care. Many of them here, this is not an exhaustive list, but we don't receive much training on this front. So those, especially depending on if you've trained more than 10 years ago in pediatric training programs, we receive very little training in behavioral mental health, and the same for our support staff. So our partners in crime, for our nurses, our medical assistants, our front desk staff, we receive really little to no training. We know well that if we just wait for kids to come to our attention and then refer, that we've completely missed an opportunity to intervene earlier and even to prevent some of these conditions. So a big failure of our current approach to behavioral mental health in primary care pediatrics. There's timely access to professionals in our community. This is a huge barrier for us, a huge challenge, and just getting worse over the past 2 years. This is expensive work to do. So starting new programs is expensive, especially starting programs that you don't fundamentally have expertise in, can be quite costly. We lack change management, project management support. We definitely lack data systems and technology to support our studying these programs and be able to really understand where we're making a difference, where we're not, and where we need to course correct. Revenue streams are getting better, I will say, and we'll talk a little bit more at the end around billing opportunities, but ongoing revenue to support these programs remains a challenge. And up until very recently, behavioral and mental health benefits were completely separate for all kids in our state. That has changed for the Medicaid kids in our state, but is still true for some kids who are commercially insured. Their medical and behavioral health benefits remain separate, and some have medical but no behavioral health benefits. So next slide, please. So when you're at the start, it's nice to think about, okay, what am I already doing? And really leverage resources that I already have, organize resources you already have. If you have someone in your clinic or in your health system who already is kind of the local go-to expert and they've been collecting resources, it's really important to leverage those. So we may already have templates, order sets, triage tools that we can start amassing a little toolkit as we are working toward truly developing and rolling out these models. And Laura and I are never afraid to steal shamelessly from others. And so there is tons of people out there who have been doing this work, both at a local level and at a national level. So steal shamelessly. There's tons of guidelines out there. There's absolutely tons of information on IHI and others around change management strategies, which is a huge part of this work. You may have quality committees in your settings that you can tap into, document sharing resources that you're already a part of, learning collaboratives that you can tap into. So there's just a plethora of resources out there when you really start looking, and definitely leverage them. So next slide, please. Really important, and what we have found, and Laura has been a master of this, is align with existing initiatives. So, wherever you can say, hey, you know what, this is already similar to stuff you're doing. If you're doing patient-centered medical home, guess what? These elements for integrated behavioral mental health, they completely line up with elements in the standards in patient-centered medical home. For those of you who have rural health clinic designation, also complete alignment around workflows for integrated behavioral mental health and that work. So it really helps people to see this isn't new and different. This really is a lot like what we're already doing. So important, similarly, that the roles are the same in many ways. So it's focused on behavioral mental health conditions, but many of us are doing care management in our clinics from a medical model, and we just have to shift our thinking just a little bit to apply it to these conditions as well, but it's really similar. And then, finally, especially in our state, there are huge state level initiatives going on to transform care, which completely support and overlap with what you're trying to accomplish in integrated behavioral mental health. So really this 2-for-1 or 3-for-1 approach to really get people to recognize this isn't new or different. You actually can do this. You've been doing it. You have experience in doing this. Really can help with buy-in at the beginning. So next slide, please. Incentives. This is a big one, right? So what's in this for me? So how can we get people to get on board with us, think about embracing this change? We all have to do continuing education, regardless really of where we are on the team and who we are. So if we can provide low cost or no cost training, providing for us who have to have our board certifications kept up, maintenance of certification options, continuing ed, training for staff who otherwise wouldn't be able to tap into this type of training. We've had some nice success around doing health literacy training, equity, diversity, and inclusion training for our smaller clinics who wouldn't have been able to tap into some of this otherwise. So just really think about what incentives, what matters to who you're really trying to sell this to, what are their pain points, and can you tap into some of those and offer some type of incentive, outside of financial. So really thinking bigger picture about it. So next slide, please. So really important to identify your program components. There isn't a one size fits all, and you really, next slide, need to think about, what do you want to do? What type of support do you want to provide? It's not an all or none. So you'll see, we'll talk about a lot of components, but you really can pick and choose which of these fit you and your system, your clinic, your institution. So we are running a learning collaborative to facilitate the work we're doing. It is a wonderful way to learn from each other across different settings, but you don't have to do it. But it's something to think about. Training usually is fairly easy to pull off, honestly, especially in this virtual environment. So think about training, how you want to do training. Do you want to do it in person? Do you want to do it live? How long are you going to do it? What types are you going to do it? Are you going to do it with everybody together? Are you going to separate by specialty? Are you going to do a hybrid? What can you record? Or what's important for people really to be together to do? So next slide, please. This is just a sample of what we've put together. So we had lots of questions about, well, who's doing what and what's required and what's optional and what's recorded. So really thinking about thinking through that up front, really what are the required elements that you really, for this to be successful, everybody has to do this. What's optional and what is optional for some and not others, and that what lends itself well to being recorded and what doesn't, and being very clear with your participants up front. So just creating some type of a grid or a schedule like this is very helpful for people to look ahead, plan, and again, see that though that looks overwhelming, not everybody is required to go to everything, and this helps to display that for them. So next slide. Consider what's most important for your practice, right? So there's all different types of partnerships to think about in this type of work, and some work for some of us and not for others of us. We have tried to go after almost any partner and every partner that we could to support this work, but there's philanthropic opportunities. Definitely in our state, Accountable Communities of Health have provided us a lot of opportunity to support this work, and more our payer partners really are coming to the table to help support this work as well. So lots of opportunity to think about partners, and maybe in places you haven't partnered well in the past or there hasn't been as much interest. We are seeing that is improving. Thinking about providing support around implementation, coaching, project management support. Many don't provide this when they're doing these types of initiatives. We have found that this in particular has led to what we feel like is a pretty successful model. And Laura's going to go into that a lot more on the how that we do that, but something to consider. It doesn't take as much resources you would think to provide support here. So something to consider. And then data and analytics. I can't stress enough how important it is to measure what you're doing, and upfront think about what you want to measure and embed capturing that data in your workflows. Big lessons learned for us on that front. And again, Laura will talk, I think we'll talk a little bit more about that, but really important to think about, how am I going to collect this data? What types of systems am I going to set up to collect it? How am I going to make this easy and efficient for everyone? And really doing it both at baseline, so you know where you've started, and to do it at regular intervals so that we can really check what we're doing, course correct, and continue to improve. So next slide. Creating timelines are helpful for our project team, and they're helpful for those who are participating. So it really helps you to chunk the work. It can be very overwhelming to think of, I don't have this at all. I don't have a behavioral health program in my practice, and how on earth am I going to get to have one? And it can be overwhelming. Having timelines is really nice to allow people to take this in chunks, predict what's coming, and plan for it. So and behind all of these little dots, there's a lot more, but this is a helpful summary view to have. Next slide. Communication, probably key to any project, and definitely key to this one. There's different types of communication depending on who you're targeting. So one type of communication, oh, I'll stop real quick. Yes, we absolutely will share the slides, Cindy. You know, who you're communicating with dictates how you communicate. So you may communicate differently and in different venues with leaders than you do with the frontline staff and the providers, and at different intervals. So you most likely, your leaders, you need lots of communication up front with your leaders to get buy-in and support. And then you probably can space out your communication with your leaders, give them updates, progress reports on a less frequent basis. But your frontline staff and the providers doing the work, much more regular communication, and you really need to think about incorporating those communications into their standard processes, so that everybody feels included, a part of the change that's happening, and that they can provide input into the change that's happening. Next slide. Oh, the fun part. So the funding and the business agreement. So if you'll go to the next slide. You really do need to spend quite a bit of time thinking about your plan for how you're going to finance this. For most of us, this is new. It's new work, and you really need to think about new funding sources to support this. We have tapped into all of these. So we have grants, we have philanthropic support, we have support from one of our accountable communities of health in the state, and support from multiple payers, both commercial and Medicaid. Our ultimate goal is to get to a sustain through value-based financing, as well as fee-for-service financing. And we really have spent a lot of time in helping our clinics to model what that looks like, so that we can give them some insurances up front that they really can get to a sustain. So really be quite creative about both where you're going to fund this to start it, but how you're going to fund it to keep it sustainable. So next slide. We have found it valuable to create business agreements with our partners. It really has, I think, just raises this to a different level of, we are committed to this. We agree that we're going to do these things, and we have actually documented them, and we've signed on the dotted line and said that this is what we are going to do to support. And we have our practices to do the same thing. They sign on the dotted line that they agree to do X set of things, so that we really upfront even are very transparent about what we're doing, and so that we can hold each other accountable and there's no questions down the road. So this is, and we do this for a lot of our projects, we found this really valuable. And sometimes we have to pull it back out and say, hey, don't you remember you said you were going to do this? And our practices do the same. They pull it out and say, hey, you know, Cheryl, you said you were going to do this, and it doesn't feel like you are. So we have found these really valuable to doing our work together. So next slide. These are just samples. If people have interest in actually seeing these tools in a little bit more detail, we're happy to talk offline. But we did create some nice Excel spreadsheets. I can't take credit for this. We have an Excel guru on the team who designed these, but really allow us to plug and play, put the numbers in advance, and think about okay, here's my inputs for revenue, here's my outputs for expense. Do I have some assurance that this is going to work? And I believe the next slide is just another, yeah, just a little bit more detail behind it. Again, if this piques your interest, Laura and I are happy to get together offline and go through this type of stuff together. And I believe that leads us to the implementation. Yes, I'm going to hand it off to Laura.
Great. Thank you. Hello, everyone. Thank you for your time today. I get the pleasure of talking about implementation support. I should introduce myself. I've been a nurse pediatric nurse for 25 years, inpatient and outpatient, most of my time in ambulatory environments. And in my current role, Cheryl and I get to support the practices in implementing whatever care transformation work they want to do. So medical home, and currently integrated behavioral health. So it's very valuable and super fun work. So we can have the next slide, please. Our hope with this is to give all of you some tools and some things to think about as you plan to do it, and that you would have literal activities and steps as you leave the webinar, because theory is wonderful, but we want you to be able to take some action as well. Begin at the beginning is my best advice for implementing something, a gap analysis, some kind of self-assessment, and that takes two parts. If you could have the next slide, please. Not only how comfortable everyone is with the work itself, what are your resources as far as community support and educational tools, but really the nuts and bolts of, do you have somewhere for a behavioral health specialist to sit in the office in a private space? If it's going to be a shared space, how are you going to flow that? Very much looking at the timing of what's going on in your practice's life. It impacts your go live date. If you are implementing a brand new EMR, if you are redecorating your office to the point that it's expanding, these may not be the right times to implement something like behavioral health. So think about your go live date. And really look closely at your tools. This was a big learning for us. The practices that we work with each have multiple EMRs, and some of them have great charting and reporting functions, and others less than great. So this has been a challenge for people when we say, hey, we would love you to have this data and we can show you this report, and their EMR doesn't quite have the functioning to do that. So that's taken some little extra coaching. So if you look at that upstream, then you have some better chance of success down the line. Next slide, please. Forming the team. So this is also, I think, very important. If you could go to the next slide, please. Having the right people in your team so that this doesn't just become top down. Here's what we're going to do, everybody, go and love it. This is really having doctors, nurses, managers, data specialists, reception, family advocates. We're going to talk in a little bit about the value of having families in your team, which we have found incredibly valuable. This way people have a peer. The MAs know the MA work best. The doctors know the doctor work best. So you're planning your interventions with them instead of for them or at them. And right from the beginning, that can help foster engagement. I know I personally don't like to be told what to do. I'd much rather be invited to participate. So, that's what you want to think about when you're informing your team as well. Next slide, please. This is a role we decided in the beginning. We didn't have a definition of exactly what a family representative or advocate could be. And as we worked together, we decided to put together a draft kind of job description for a patient and family advocate. And that's going to be a handout that you'll all be able to take with you today. And this was created in partnership with our family advocates, because we didn't want to define them for them. We wanted to define with them. And there's a lot of variability in what you can do. Some of the family advocates wanted to come to all of our implementation meetings and give us feedback in the moment. Others wanted to be more of a peer phone a friend if a similar family was having an issue in clinic, they wanted to be peer support for the family. So there is a lot of opportunity to engage with the families. And this was a little bit intimidating for some of our teams because it's like they're looking under the covers at what we do in clinic flow. And, you know, in reality, the families see us anyway. You know, whatever we think, we're glossing over it, they see us, they want to partner with us. So including them, I don't think we had one negative feedback or interaction from having a family involved. So that was fantastic. Next slide, please. Standardizing your roles. So this goes into if you have expectations of your team and of this work that really need to be clear about writing them down, defining them, and making sure they're accessible to your team. If you could go to the next slide, please. This is our personal favorite model. This is from IHI, the Plan, Do, Study, Act model. We apply this to all of our care transformation work. So the Integrated Behavioral Health Plan was no different. If you could go to the next slide, please. And when we do our implementation coaching, we had a two-person model as the coaches. So I come from a nursing and process improvement background. Our project manager for the Integrated Behavioral Health Project has the content expertise and the subject matter, and it was really successful for Sophie and I to come at this together because I don't know all the answers, she doesn't know all the answers. Together, you know, we really can partner with the clinics and meet them where they are. We found that having a standard agenda that included everything for every single implementation meeting was really helpful. And why is that? So we did not in the beginning start talking about data upstream that Cheryl mentioned, you know, how data is so important. We sort of waited till close to the time the data was needed and then started talking about the data. But that's how we ran into some of the challenges with reporting, et cetera. And it was more of a surprise to people because they were focusing on the workflows and the role definition. So that's when we had to go back and dig out the agreements where we all agreed to do data, but it didn't feel as good as it could have. So now with our second cohort of practices coming in, we're making a point of calling out expectations for data, questions about data, inviting our analytics peers to these implementation meetings so that they can speak to it directly. The data person on the practice side can come to these meetings as well. We initially, for our first cohort, scheduled these once a month, and that was sufficient for the practices that already had some level of behavioral health on site. For the practices that we're starting absolutely from scratch, we're feeling like twice a month would be better. So with our second cohort, we're going to do every 2-week meetings to really give that extra level of support. Change management, workflow documentation. I'm an old nurse, so if you didn't write it, you didn't do it. You know, writing things down, and whether it's a decision tree, if you've got visual learners, that's part of what we help the practices with. If you could go to the next slide, please. So we had several different roles that we proposed for the practices. Now, some people had all of these roles, most of them did not. So people asked, can one person be the day-to-day manager and the data lead? Sure. You know, you just need to consider what's the realistic ratio of your workflow. The day-to-day manager might also be the manager for the practice and might also not be as skilled with the reporting in the EMR. So, you know, looking at who on your team can help fill these roles. One of our other big learnings was as you are planning your care manager role, your behavioral health professional lead, really consider what is a realistic ratio. we want to save the world, right? All of us want to make sure that the children that can't receive mental health care outside of our walls can now receive it inside of our walls. But you also need to do this right rather than fast. So if your panel is small, you start small, you work through your processes, you pick the different pieces that work and don't work, and then you expand. You know, otherwise you're going to be inundated with patient care and you haven't figured out your charting workflows, et cetera, yet. So start small, be realistic, and then go out and save the world. You could go to the next slide, please. That would be great. As you're looking at your workflows, I feel like it's important to not only consider the you're in the building part of it, but a lot of what we do day to day in primary care is what happens before the patient comes in, of course, the clinic visit, and then what happens afterwards. So, you know, people are going to call in. Do your nurses have the information to answer the questions? Are you going to include IBH in your preclinic huddles or in your chart prep? And that involves a ton of communication. So, you know, if you're doing recalls with reminders for visits, who's going to make those calls? You know, is it the same person who's making your due for your 5-year-old checkup call? Is it going to be in the portal? Is it going to be a phone call? Is it a letter? All of these things that you can begin to consider. When you're designing an integrated behavioral health registry, we had some templates and some support from our analytics team who are wonderful to really help practices figure out what kind of a registry works well for them. So is it an Excel spreadsheet because, you know, your EMR is a little more complicated? Or do you have something already existing in a population health tool or in your EMR that you already can leverage and add your behavioral health work to that tool? So there's a couple of options there too. Next slide, please. Data and more data. Next slide, please. So having the baseline data, we always coach our baseline data collection of, it's okay if you don't have all of this information. It's okay if your numbers are low. That's the purpose of us doing the data collection, is to show what we were able to improve, what we're still running into barriers with. So, you know, really identifying upstream the data that you want to collect. And we focused on some basics. Annual screening. What ages are you doing annual screening for? Following up of those screens, so you don't have anyone lost to follow up. Really looking at first line med management for common behavioral health conditions. We were not expecting people to right out of the bat handle anyone who is psychotic. You know, really wanted to look at what was appropriate for primary care, and then did you have the mechanisms in place to refer as needed in an effective way? Next slide, please. We also found it really helpful to tie our process and outcome metrics directly to the expectations of the project. So if we expected people to implement templates grounded in evidence-based guidelines, we collected data around how many practices were able to do that. Who was using the registry, who was still struggling with their registry. Standard processes for referrals. This is the referral process internally within the practice as well as externally. Sometimes has the same process and sometimes it's different. So that's one I would recommend you look at carefully. In the smaller practices where you would lean down the hallway and say, hey, I'm going to send a kid to the care manager. Okay, great. I'm exaggerating to make a point. You know, in a larger system, you may need to put in an order so that you can track it. How do you know how many times you talked down the hallway to someone and said you're going to refer a kid? And these data speak very loudly to the scientists on your team. You know, what's in it for me, or how do we know this extra effort is making a difference? The data is going to help you tell that story, and it can be very validating for the team. Next slide, please. We did, as part of our baseline data, and you'll have a copy of this in your takeaways as well, something that was called a provider comfort scale. And it was just a 1 through 5 system, but how comfortable are you as a provider managing, the following conditions for a school-age child and an adolescent? And there's probably maybe 5 or 6 questions on this. Happily, we noticed that our comfort levels went up just about across the board. Not every practice had the same improvements because their populations are different. We have some very urban and some very rural practices. They have their own challenges of population. But it was very interesting and valuable for the practices to see that, people are feeling in general more comfortable as things went along, because it's not only about the care we're providing, but how comfortable and confident do you feel in providing that care? Not everybody's comfortable even talking about behavioral mental health. So this really helped teams get a picture of that. And we were able to provide at a network level, all of our practices together. Here was the data, but we were also able to give each practice, here's the results for your particular team. And that way they could see everybody and their particular data. Next slide, please. Standardizing the process, tracking, and visual systems. This is my personal favorite part of the work. I think I had the big coloring box as a child. So, visual systems are very, very fun to me. If you could go to the next slide, please. So we had a couple of options for the practices. We had on the left there a very detailed tracking tool. So that is a tool that Sophie, our IBH practice manager, and I will use during our calls. We go through, what are the strategies, what are your goals, we help document it. And then that tool on the right is a one-pager summary where we record all of those decisions, and the practice can see at a snapshot, of the 10 things that they needed to accomplish, in that particular visual. 4 of them are green, the others are in progress. It also gave us a good opportunity to say, some of these goals are really big, so you're not going to accomplish them in a couple of months, and that's okay. I think there's a lot of power and value in saying, it's okay to not be all green, especially for the overachievers on your team. This is going to take time, it's going to take revision, and it's going to not all be all green all the time. Next slide, please. Our fantastic analytics team put together this dashboard of our data. Next slide, please, is another view of the same information. And it really helps see year over year, visits by provider, visits per patient. Our teams particularly love data. So this was something they've been looking forward to. Next slide, please. Motivation and change management. Next slide, please. Taking those pieces of your data and posting them somewhere where people can see them is really helpful. You're going to check in with your team, yes, and you're going to really talk with them and solicit their feedback about what's going on, but showing them the graphs and charts and even talking with people about it one-to-one. It doesn't always have to be, we only talk about it at staff meeting or we only talk about it at huddle. If you really make this an integral part of things where people have to pass it on their way to the lunchroom, it gives you opportunity for those in the moment check-ins. And what is the care team feedback? What questions do they have about data? What data might they like to see in addition to what's out there? And my other favorite, did you fix one thing and break something else? So, if you have a great idea for workflow and you find that it has just brought clinic flow to a grinding halt, then you need to back up. You need to take people's feedback and back up and see how you can pivot on that decision and avoid those unintended impacts. But acknowledge when they happen, because that's real life. And that's good for people to give us that feedback. Next slide, please. Having a forum for providing feedback. Again, this is a nice opportunity to, of course, do this at all staff meetings. You have your challenge. Whenever I used to be a clinic manager, and I would put up a poster Not everybody was comfortable coming to me and telling me all of their ideas. Others were very comfortable. But for the people that preferred to give feedback kind of anonymously, I would put up one of those big poster pieces of paper on the team room door, draw a line down the middle and write challenges on one side and opportunities on the other. And then as people went through their day and they came across something that they thought was an opportunity for improvement or something that they were finding very difficult, they would write it on the poster. And then I could go in and check off, oh, great, I saw your feedback. Thank you for that good catch. And then really, I was accountable to follow up with the team again on their questions. So if people feel like they're asking questions in a vacuum and nobody gets back to them with an answer, they're going to stop asking questions. So, really making sure that you have a way to give that feedback back, even if your answer is no, even if your answer is not right now, really having a visual way to have people ask questions and to show them that you're listening. Standard agenda items at team meetings, giving that little bit of time at your nurses meeting, at your MA huddle. The MAs will have ideas and feedback for each other that they can build on, but also having that interdisciplinary all staff forum for team meetings for feedback is also helpful. Next slide, please. Wanted to give you guys some example of balancing measures that we worked through some of our teams with, and I won't read all of these, but if the challenges were we didn't know where our forms were for patient ed for this child that came in for depression, then you can look at your pre-clinic work and say, is that something we can do in chart prep? Is that something we can talk about at huddle, so that we have opportunity, before the day comes in the door, to collect your materials and plan your day in a calm, cool, and collected manner. For post-clinic, more things of if something wasn't able to happen in the visit because the family had to leave, what's your process for following up with that family and saying, hey, can I help you get scheduled for that follow-up? Or, and I noticed that, we didn't have it, that our printer was broken and we didn't give you the handout that we talked about. How can I send that to you? Is the portal better? Should I put it in the mail? Things like that sometimes will require a clinical person, an MA or a nurse, and sometimes your front desk folks can help with this too. So it doesn't all have to rest on the provider's back or the behavioral health manager's back. This is the shared work that can be spread across your clinic continuum. Next slide, please. Ongoing motivation. So once you start motivating your team, please continue motivating your team. Your champions are going to be your best advocates in this. Continuing to look at the what's in it for me. We all are in this work to help save patients and families, but if we don't recharge our own batteries, we don't have a lot to give. So I think it's very important, especially in this time of COVID and what's the new vaccine schedule of the week, and we're doing video visits, now we're doing in-person visits, really keeping an eye on staff morale and engagement. I'm a big fan of reframing. So someone's, oh my God, there's always one more thing to do. Why is it always one more thing to do? Acknowledging it is another thing to do. We are doing more work. Let's look at this data and see that, we've helped 200 children in the last 3 months get care that they wouldn't have had somewhere else. You're not invalidating the one more thing to do, but you're connecting it to the value of, look how many people we helped, look what your effort has produced, and helping people maintain that morale and that self-care. Next slide, please. Continue tracking your progress. Be really creative in your communication systems. If you have one visual that you never change, people become kind of blind to it. So, what arrow stickers do you have? What, changing colors can you have? You can do trivia. You can do quick tidbits of information. Locate your visual system and your data near your poster where you're asking for people's feedback, because then they can look at that and give you some feedback. In pediatrics, we have a high focus on silliness and fun because we're working with children, but adults can very, very much benefit from that as well. So we're all working hard, but, you know, it's okay to take the time to say, you know, I can't pay you an extra, you know, $50 bonus for doing this work, but why don't you take an extra lunch break today? You did a really good job, or that was a really hard interaction with that family. Why don't you just take some time to take a walk with the kudos card? You know, chocolate goes a long, long way. Next slide, please. Success stories have been extremely valuable for us. So not only through our family advocates, but the providers in the clinic implementation calls would start to tell us amazing stories about having a better handoff to the emergency department. Or a kiddo came in for a regular visit of stomach pain, and they were able to use their integrated behavioral health toolkit and skills and team to help see that child was suicidal. And that was not on anybody's radar. So, you know, things that are empowering the team to help in the moment and look where maybe they didn't have the tools and the experience to look before. Next slide, please. And I'm going to hand it back to Cheryl for sustainability.
Oops. Thanks, Laura. Yeah, I'm going to wrap this up real quick. So hopefully we have plenty of time to, Laura and I would really much prefer just to talk with you guys. So hopefully we'll have plenty of time for some dialogue. So next slide. So, we talked earlier about, starting small. And I do believe that, it really does build on this improvement science, right? To really start with a small test of change, study it, but hey, then at some point you're ready to go, right? You're ready to expand. In my clinic, we started very small. We started with teen depression, anxiety in a very small age group. We build our program, we put all our processes in place. And then we said, okay, I think we're ready. It's really kids with disruptive behavior who we are seeing a lot of, whose parents and caregivers are asking for help with. Are we ready? Can we expand what we're doing to that group? And what I think has been most rewarding is to see happening is our practices who are a couple years in now saying, actually, I would love to get upstream of this and try and prevent some of this completely, and are really starting now to focus in the much younger age group, 0 to 5. And saying, okay, what can we do actually using this embedded model with our behavioral health professionals to actually prevent some of this from happening in the first place. So that's really fun to see happening. And it really is part of how you scale this. So you can take what the small population and the processes you put in place and now start expanding it. And ultimately where you want to get to is, this is just business as usual. So this isn't something new or something different that we're doing. This is now the way that we provide care, and get to the point in my clinic where we had during in early COVID, there was rumors that our behavioral health professionals were going to be on the furlough list, and several of us saying, well, then I'm not coming to work, right? That this is the standard of care for us now. This is a vital component to what we do in providing care. So that's where we hope everybody gets with this. And next slide, I think, yeah. So you really have to think about all these different components to be able to get there. So people come and go. So, docs leave, our behavioral health professionals, we have had turnover already in one practice. So what is your plan then of incorporating that new person into this model, especially if they didn't come from somewhere that was doing this model? So what is your ongoing training for that? What is your ongoing plan and process for incorporating new team members into this so you can continue your sustain? What about your data? So there's a huge lift to start collecting your data and looking at your data, but over time, it's easy to drift away from that and stop doing it. And there's been some nice, actually, data research coming out from the Ames Center, looking at fidelity to the model and maintaining outcomes over time. And probably no big surprise, the less close you get to the model, the worse your outcomes then become. So it is important to kind of stay on this and to continue to look at your data, track your data, make sure that you're staying you're really being true to the model that you designed and created. And if you're not, be able to course correct. So next slide, please. Oh, yeah, references and takeaways. So there's all types of, if you just go to the next slide, just as an example, we don't have to go through all of them. There's pages and pages of links. These are just all helpful resources that we have found, that we have used, that have contributed to some of the work that we're doing. And it's kind of all over the board, the types of references and resources they are, but hopefully you guys find them somewhat valuable if you're pursuing this work. We did check all of the links as of about 2 weeks ago. They all worked and they all took you to the what they were supposed to. So hopefully that'll be the case once the presentation gets to you. And I answered this in the chat, but I just wanted to make sure, I think, let me make sure I address who asked this question. Tim. Hey, thank you, Tim, for asking about, hey, why weren't the behavioral health professionals on those early slides? That just reflects the reality for us that there aren't behavioral health professionals in our practices. So when we're doing some of the planning, they're not there because they physically don't exist yet for us. But they are a core member to our team. They're on our, we have a core team. Everybody has to have a PCP champion, a behavioral health professional, some kind of clinic leader, manager, and a family advocate as their core, making up their core team. And then some of the other team members we're flexible about. So definitely they're core to the team, and so core that we actually provide a significant amount of financial salary support for our behavioral health professionals so that they have time and opportunity to help build these models without having to see a full caseload of patients. So we completely acknowledge the work and the value they bring and provide a bunch of salary support for them so that they have the opportunity to be available to both do the trainings, but to participate in the development of the model. So really important to us. And then it dawned on me, we've mentioned Sophie several times, and some of you might be thinking, well, why isn't Sophie there? So when Sophie is our integrated behavioral mental health program manager, who is vital to all of this work and an expert, has behavioral health background. She was not with us when Anna and friends asked us to do this presentation. So she is just a little over into a month with us. We were in between program managers. So we didn't have a program manager in place when Laura and I agreed to do this presentation. Otherwise, she would be here. So I think that's it. And we're happy to open it up to questions. And so chat or Q&A, I think works. Either one. Is that right, Anna?
That is correct. So I think Zoom is a little tricky with these webinars. So I think ideally if you all could put your questions in that Q&A box specifically or in the chat and we'll kind of start monitoring, that would be great.
Yeah, I see Cynthia just acknowledging that, yeah, there were a lot of behavioral mental health professionals on the call today. So thank you. I acknowledge, this is a model. So doing integrated behavioral mental health in primary care, so this way and not the opposite, primary care being in a behavioral health setting is a different model, and both with real value, but really, I believe target different patient populations. So we are really looking at integrated behavioral mental health in a primary care practice because that's who we are. It's we have primary care practices as part of our network, and really thinking about serving the majority of patients and families who come to primary care practices versus the other way around, which I actually think there's lots of value in primary care being in community behavioral mental health agencies too, but targets a different patient population.
We can just give folks a few moments to type in their questions. Well, while we're waiting, if other folks have questions, I'm wondering, Cheryl and Laura, I have a question actually. Here, I'll put my video on. But I am wondering, just given that you've developed this really amazing model, if you had kind of additional or in an ideal scenario, unlimited resources, where would you want to take the model next? Or what would kind of be your vision for next steps on how to continue to strengthen it?
Do you want me to start, Laura, or do you want?
Go for it.
Yeah, I mean, I spoke to it a little bit at the end. So I am personally, because I'm a general pediatrician, really interested in primary prevention. And I do believe that there's a lot of opportunity for us there in really incorporating behavioral mental health professionals in our well visits that we're doing from the earliest ages. So very early in fostering a positive relationship between caregiver and children, and then on down the line, in anticipating the challenges that come at the different age groups and really getting upstream of that and helping to do, giving our parents skills to be successful. So I think there's lots of opportunity there. There's not today, not good ways to model that financially in primary care practices, because you can't necessarily bill for preventative services, which is those types of preventive services, which is a challenge for us. The other thing we're looking at is we acknowledge that not every practice, at least in the short term, is ready to put a behavioral health professional in their practice and the reasons are all over the board on the why, but we still want to serve the patients and families in those practices and support the practices. So we're thinking a lot about beefing up behavioral health navigation for our practices, as well as being able to provide low-level support, so psychoeducation for patients, families, while you're waiting to connect with services, a little bit of coaching on self-help tools. So we're really good about saying, hey, there's these apps and here's some resources, but then we're not good about then the next week calling, checking in with the patient and family and saying, hey, did that work? Did that help? Did you try that out? How's it going? So we hope this year, actually, maybe by next fall, we got some additional funding to be, we're hoping to pilot that concept and see how that goes. And then let's see, I will read this. We're looking to expand our integrated behavioral mental health population to include peds. Concerned the demand is higher than our available resource. Yes. Did you find particular interventions were best for starting out? That's an excellent question. It's been different in our different practices. You are absolutely right. Depending on how you do this, you can create the same capacity problem in the clinic that exists in our communities. So one thing that we've really been advocating for is short-term brief interventions where appropriate. And in primary care, that's actually appropriate for a significant portion of our population. So 2 sessions, 3 sessions, 4 sessions, which Elizabeth and Larry talked a bit about at the first seminar. So this isn't 16 weeks of CBT for every single child or longer. To really do brief interventions when appropriate so that you can keep capacity is one way to do that. And the other way is to start small. So talk with patients and families, as well as the clinic of where's the highest need. And for many that is in they did end up starting with their teen population, concerned about the increasing suicide rates and suicidal ideation rates that now that we're screening universally that we are finding. So I think you can use those complementary brief interventions and targeted populations as a start, and then over time grow. Because you're right, we're in primary care, would say before the pandemic, about a quarter of our visits had some behavioral mental health component. It is well over half now for us in primary care. So you absolutely, if you're not careful, could outpace your capacity really quickly.
And I'll add as well that the FAST training, also FAST, that Matt and Erin are going to talk about in the next part of the webinar, a lot of our teams have found those to be really helpful interventions as well. So more for the, our individual psychotherapy is full, our collaborative care manager is at capacity, but here are some tools we can work with the families. And I know they'll have a great presentation on that next time as well, that the teams have found that really helpful and really useful, actionable tools. One of the other things we talked about in a similar way is if you have one provider who is super eager and they refer all of their children to the care manager first, how do you share the wealth equitably among the practice? Is it always first come, first served? Is it acuity, et cetera? And the answer is it's a little bit of both. So as a team, this is something you can do upstream. Is talk through, we're getting ready for go live date. We want all of the providers to be able to have a chance for some support and really talk through that and keep an eye on your patient panels. And, if you do have, it seems as if, and I know Cheryl, in your practice, you have the complicated kids in your team, that there's generally someone on the team who is very skilled at working with the complicated kids. So they may have more need for the time of the care manager, but really talking about that as a team upstream and making sure that that resource is shared equitably is also important.
Yeah, and just reflecting on Joy's comment and question around, we didn't talk a lot about the actual model because that wasn't exactly the focus of the visit, but we do, we train all of our clinics on the AIMS collaborative care model, but that is not the only thing that they are doing. So we are actually have a hybrid of model and we really allow our practices to create a model that's responsive to their community. So what we're doing looks a little different in every clinic. So all the clinics have some collaborative care going on, some a lot, some a little, but all of them have, I guess now have seen that having a behavioral health professional in their practice, it's like, why haven't we done this? Why weren't we doing this? This is such an invaluable member of our team now for our practices and for me personally in my practice, that it kind of feels like, why did we separate this? Why weren't we doing this from the beginning? And I really, as I mentioned, when Anna asked, I am very hopeful that we, at the very earliest visits, that we'll be able to create models where we can incorporate our behavioral health professionals and working with our patients and families, because I just feel like there is so much opportunity there.
We've also found that the behavioral health specialists found value in having kind of office hours for the providers to come by with, hey, I've been worried about this kid. What do you think? Which intervention could work? In addition to having their own time to review their panel and see patients on their own. But that value of floating among the team or being available for impromptu was also a nice way for them to start and get to know the clinic and the flow.
Thank you both so much, Cheryl and Laura. I think we'll give it maybe 1 or 2 more minutes just in case there are any final questions. Any last questions that folks have, and then we'll start to wrap up. So if anyone has any final questions, feel free to put them in the chat or put them in the Q&A box before we then wrap up for the end of the webinar. And I think Laura and Cheryl, if you have any other last kind of things to add about your presentation, this would be a great time to give those comments.
We were talking as we were putting this together that a lot of people helped us put this together. So we're both very happy to talk with folks offline and et cetera too. So this doesn't have to be your only chance at doing this. We want to pay that forward. That a lot of people shared their best practices with us, and we are happy to do that as well.
And I guess that my one closing thought is we really, most of us have started these models because we are being responsive to patient and family needs in our practices. But for, I think universally for all of us, it has helped us too. So the providers of the care. So it really, I feel like it really is a way to help with burnout in primary care. I leave clinic most of the time now feeling like I provided pretty good care today. Like I connected that kid with the resources they need. I was able to give them to start them on the right path. And I did not feel like that before I had a behavioral health professional in my practice. I often left thinking I didn't do anything for that patient and family. I have nothing to offer them. I don't have the skills to take care of their needs. And I don't have the person here who can help to take care of their needs. So for me, it not only helped our patient and families, but it really has helped the providers in our practice and our satisfaction in what we're doing and our burnout. So, which was an unanticipated consequence, I think, of doing this, but another great reason, especially during the COVID pandemic, to think about these types of models.
Absolutely. I was just going to say, with the kind of increased need for behavioral health care, especially for kids, especially for, Medicaid populations as well, this is just an incredibly important model. And it looks like we have a question from Cindy. Are you seeing any burnout among behavioral health care managers?
Yes. And it depends on the what we're noticing is yes, Jonathan, yeah, definitely out in the community. This is true. I know. Well, just as an aside, so Bob Hilt, who's the medical director of the Patient Access Line, just publishes a monthly newsletter, and he quoted that our community mental health clinics are down about 40% in staff across the board. In some regions of the state, it's worse. Some are a little better, but that's about what it is. So yes. And for many reasons. But we have, and what we've noticed in primary care is if your behavioral health professional is providing traditional psychotherapy, but they're just doing it for your patients, those individuals are burning out really quickly because they get filled up to capacity quite quickly with some potentially pretty complicated kids. And they are burning out. And so we did have one practice that happened. That's how they were using their behavioral health professional. And she left. What did she make it 18? How long, Laura? 2 years?
Probably just about, 18 months.
And so they're being very mindful that these models can actually help with burnout if you can keep a varied patient panel. Right? Because you can't have everybody be real complicated. That's really, really hard. And it's part of why people burn out in community mental health. So if you can keep that, hey, you know what, here's a kid who he just won't go to bed at night. And mom's really, really struggling with it and super frustrated, and she's not sleeping and he's not sleeping. That's pretty relatively easy to address. And yes, you have a kid with pretty significant depression that maybe you're helping, but to keep that panel varied, I think, is part of the key to help with preventing burnout in primary care.
Great. Well, on that very relevant note, it looks like we have another question from Jonathan. What about the CS who are supervising other mental health clinicians?
I'll have to ask you what CS is.
Clinical supervisors.
Oh yeah, we do. So we aren't. Yeah, we're a little different than community mental health. So we don't have clinical supervisors that. So our behavioral mental health professionals, in most of the practices, are employed by the practice. So it's different, right? It's a different model. They don't have a clinical supervisor. It's more like being in private practice, kind of, in some ways, for the behavioral health professional, except they're not by themselves, but there isn't somebody supervising. There are two of our practices are contracting with for services through a behavioral mental health agency, and they do have clinical supervisors through that agency. So a little different. What is your role of your behavioral health manager? Yeah. So so for us, our behavioral health managers are serving dual roles or purposes. So they are providing direct behavioral health services, and they're serving for most of the practices, and they're serving in a care manager role, behavioral health care manager role, so they are both tracking the patients on patient registries, ensuring that the patients are getting connected to services if they're referred out, making sure they're coming in for their appointments with us. So in that manager role, and they're providing direct services. So for most of our practices, our behavioral health professionals are a dual role. A few have separated, but not most. And I think at the end of the day, the ideal for all of us would be that those are two people, but we have not figured out a way financially to sustain that yet.
We've also found some creativity in the fact that some of the teams have a licensed clinical social worker, and others are not able to bill independently yet, but they're the right person for the role. So what does that creativity look like as far as collaborative care and care management to start your program small, and then, you know, once the licensure can be obtained, you can PDSA your process and see what's what. But hiring has been a challenge and burnout a challenge. So we've had a lot of creativity in scoping that role as well.
Yeah, I'll read. Oh, let me scroll. Okay, I will read Cindy's question. How do you go about ensuring that the behavioral health professional's caseload includes a balanced combination of light and more complex cases so that that person doesn't burn out? Yeah, excellent question. You know, that's really a joint effort between clinic manager, PCP champion, and the behavioral health professional to try and keep level load. And then take that back to, because it's the primary care docs who are referring the kids typically into the behavioral health services. So to really monitor that, and that setting up all this tracking in the beginning, that helps because you can monitor that and you can pay attention to what types of kids are you serving with what types of conditions. And we've had to do this in my practice. Occasionally, we've had to say, no more referrals for teens with depression, can't handle anymore. I've got 12 kids I'm doing true CBT with, and I can't have any more. So it's really a negotiation, I would say. Wouldn't you say, Laura? I think but the tracking tools really help to keep an eye on that.
Absolutely. It's just like we talked through, a PCP would have time for sick visits, well visits, and consults on their template. That if you take that idea and apply it to your behavioral health registry, then as you're looking, if your whole registry is full of super complex depressed teens, and you don't have any availability, that's a good way to look at, you can, if it's an Excel, you can filter your list, but really looking at one behavioral health care manager can handle X amount of complex patients and X amount of simple short-term patients, and tweaking that as you go along, but really starting small. We had one of our practices who were super eager, and they went at it full force, and they've had to rewind a little bit because exactly like we mentioned earlier, they were at capacity very quickly.
Yeah, and I think Roxanne is asking about ongoing tracking once they're not kind of formally receiving services, if I understand that correctly. Do you want to talk about that, Laura?
Sure.
Would you mind just reading it out loud? Oh, sorry, reading it out loud. I don't think everyone could see that one.
I'll read it. It says, is there a follow-up after kids leave the case managers and are on their own, since there's a huge burnout? I'm guessing once they're gone, it might be a disadvantage to follow up like a wellness check. This is an excellent and timely question, because we're just at the point now where we're going to work with the AIMS team on something they call relapse prevention planning. So not only that, if you have patients that are hanging on because they love working with you, but they don't really need that resource anymore, how do you help them discharge and empower themselves? On the other hand, if you have patients you've tried to reach out to several times and they're completely lost to follow-up, what does that look like? For those patients in the middle who have completed the therapy as you planned, what does that relapse prevention look like? So that's a part of our sustain that we're just getting into now. So that's an excellent question. And yes, absolutely something that is going to be on the radar.
And it looks like Tim has a question. I'll read it out loud here. I work in a student-based health center, and we have a lot of need for more urgent care mental health service. Have you worked at all with some spaces for this kind of more drop-in service?
Yeah, that's an excellent question. Seattle Children's we have stopped and started on having a true like behavioral mental health urgent care service, which is paused, I would say, right now. But in my clinic, if we see them, so if they come in and they see one of the PCPs and we recognize this, we do a warm handoff to our behavioral health professional. And even if she's not who they're going to see long term, she will serve them in an interim for a couple weeks and help us get them connected to care. And now that this is what we do, and this takes time, but now our patients and families understand that we have this now, and this is the model of care. They have gotten better about reaching out to us too and saying, hey, I need some help. So even if you're not there in front of them or they're not presenting to clinic, they know they can call us for this type of help. And again, we can do a warm handoff, and we're all of us are pretty good now, front desk staff all the way back, recognizing that these patients and families may call. Leslie has a confidential voicemail, a direct line, which is different. You cannot directly call me. You can't directly call anybody else in the clinic, but you can for our behavioral health provider. And she has her own confidential voicemail, which is also unique. We don't have that for anybody else. So we have tried to set up personally some processes in our practice, and definitely the patients who have engaged with us maybe 2-3 years ago did great. And now there's a crisis. The door is open for them. So they can call back, and they do, and they just ask if they can talk to Leslie, who's our care manager. And so we've created some processes in our own clinic for that. And then, as I mentioned, when Anna asked about what's next, we are trying to create some capacity to do that for our whole network. Especially for those who don't have a behavioral health provider, that when you acutely need something, but you don't need ED, that we actually have something to offer you.
Wonderful. Well, I think just noting the time, unless there are any final questions that come through the chat, I think we'll probably take this time to start transitioning and wrapping up. So thank you again, everyone, for these excellent questions and this wonderful conversation. And a particular thank you to our wonderful presenters, Cheryl and Laura. This was an incredibly rich and informative presentation. I know I learned a lot. So thank you, everyone, for being here. We hope you'll join us for the next installment of this webinar. So we're skipping next week due to the observed holiday. So part 3 will be on December 3rd from 1 to 2:30 as kind of a final wrap up for this presentation series. As a reminder, feel free to reach out to us if you have questions for our presenters about the CME credits, and please feel free to fill out our post-webinar survey as well. We really appreciate the feedback. So thank you again to our amazing presenters, and I hope everyone has a wonderful weekend. Thanks so much.
Yeah, thanks. And I'll plug Nat and Aaron one more time for next week. I think you guys will, especially for all the behavioral health professionals out there, I think you will find what they're doing very helpful and action oriented. So we hope to see you in December.